The Excerpta Medica Foundation, under a grant from the Borden Company, is pleased to bring you the 11th seminar in this postgraduate pediatric review series, Clues to the Early Detection of Birth Defects. The discussion will be divided into two parts. Those clues which are to be found by the direct examination of the newborn infant, and those which are detected through interviews with the obstetrician, the pediatrician, and the mother. Chairing our panel is Dr. Sidney Gellis, Professor and Chairman, Department of Pediatrics in Boston University. With him are Dr. Kurt Benerschke, Professor and Chairman, Department of Pathology in Dartmouth Medical School, Dr. William Blanc, Associate Professor of Pathology in the Columbia University Presbyterian Medical Center, Dr. Edith Potter, Professor of Pathology in the University of Chicago, and Dr. Joseph Walkeney, Professor of Pediatrics and Director of Pediatric Research in the University of Cincinnati. Dr. Gellis will open our discussion.
The subject that we will discuss today is a very extensive one, which cannot be completely reviewed in the allotted time. We shall therefore confine ourselves to areas in which information is relatively new, and will stress those clues which have received little attention in the past. We turn directly to the examination of the newborn infant, seeking first the clues which should alert the physician to conditions which are immediately life-threatening, and secondly, the clues which point to the possibility of major congenital defects which do not threaten life at once, but are of great significance. In examining the newborn infant, it is very important to pass a catheter into the nasopharynx of the infant to make sure that there is no possibility of choanal atresia. If the catheter cannot pass into the nasopharynx, a life-saving procedure to this infant would be depression of the tongue with a tongue depressor in order to permit air to flow in and out of the infant's mouth. The newborn infant being practically always an obligatory nose breather, it is essential that this procedure be carried out to permit him to breathe. The same catheter having been passed successfully into the nasopharynx and thus having ruled out choanal atresia should be continued on down the esophagus. For failure to pass the catheter successfully into the stomach permits an immediate diagnosis of esophageal atresia, and the earlier this diagnosis is made, the more successful the surgical outcome of this particular abnormality. The catheter may give additional clues to obstructions further down the gastrointestinal tract, namely atresia of the duodenum, since if large quantities of fluid are obtained by the catheter into the stomach, this abnormality is suggested immediately and can be confirmed by passing a small amount of air into the stomach to see how promptly it moves through the duodenum into the intestine. The same catheter having been removed from the esophagus should finally be passed into the anal opening, since an obvious anal opening does not necessarily rule out an atresia somewhat higher in the rectum. Now, if the infant is having respiratory distress and choanal atresia has been ruled out, it seems vital to have the pediatrician view directly the larynx with a scope and pass a catheter down into the larynx in order to remove any mucus plug, and at the same time to rule out the diagnosis of laryngeal atresia, which is a life-threatening condition, and the infant can be saved if a tracheotomy is done immediately. Dr. Potter, you have given a good deal of attention to diaphragmatic hernia as a life-threatening condition in the newborn. Would you talk about this?
Well, in our experience, this is much more common than the other things you've mentioned that may be life-threatening immediately. And whenever you have any baby who is vigorous with good tone at the time of delivery, who doesn't breathe, who's making some attempt apparently to do it, but who isn't getting air into his chest, the first thing you think about is a diaphragmatic hernia.
Would you say anything to the clues that are present besides respiratory distress, which suggests this diagnosis?
A scaphoid abdomen is very important because when you have a major defect in the diaphragm, most of the intestine prefers to be up there instead of remaining where it belongs. So that a lack of normal fullness of the abdomen is certainly one very important thing.
the examination of the infant for minor defects may serve as a clue to less obvious major abnormalities. One area in which there has been considerable interest of late is the appearance of the ears, and Dr. Potter, you've called a considerable amount of attention to abnormalities of the ears and agenesis of the kidneys.
The ears are only part of a total facial unusual condition that you see in babies. I think we don't pay enough attention to just the way babies look. And any baby with renal agenesis, of course, if it's complete, will tell you that it doesn't have any kidneys. All you need to do is look at its eyes with their prominent epicanthic fold, the flattened nose, the cleft below the mouth, and the ears. The ears are often low set. They are at more of a slant than normal, and they're flattened against the side of the head and assume a very peculiar shape. You do see abnormal ears in many conditions. This is one of the things that one looks for when one's trying to decide whether a baby has Down's disease or not. There has been some attempt to show that you have a unilateral abnormality of ear when you have a unilateral renal abnormality. We haven't been able to confirm this fact, but I think we're going to constantly learn more and more about the significance of not only ears, but all parts of the face as far as the diagnosis of many different types of abnormalities are concerned.
Dr. Blanc.
We still don't know exactly what is the meaning of the ear. We cannot tell that any newborn baby an abnormal ear should immediately mean a bad prognosis, but I think that any baby having an abnormal ear should be submitted to a very thorough examination and all other malformations excluded.
I agree with you completely. A grossly abnormal ear on one side without other stigmata suggesting the mandibulofacial dysostosis picture has led to the taking of an intravenous pyelogram and a very excellent payoff by this procedure with abnormalities which are amenable to surgery. I think it's important to stress that in the child who has mandibulofacial dysostosis or Treacher-Collins or Francessetti's syndrome, that hearing tests be done very early to determine the presence of deafness, and thus by the use of a hearing aid preventing the development of a deaf-mute child. As we move on down from the ears to the eyes, we've already heard mention of the abnormal folds around the eyes and agenesis of the kidneys. Brushfield spots have been reported as occurring very frequently in the child with Down's disease. This may be helpful in the newborn period, but it's important to stress that Brushfield spots may be found in many normal babies. I think we might mention briefly the importance of hypotelorism, that is, an abnormally shortened distance between the two eyes, and its relationship to central nervous system abnormalities.
One of the main defects which goes along with it is the variety of malformations grouped under the name of arenencephaly. These abnormalities consist of a fusion or an absence of normal division of the ventricles of the brain, malformation of part of the renencephalon. Many of these babies are very close actually to the cyclops, and I think Edith is using the wonderful name of half cyclops to define some of those babies because they have abnormalities of the external nose and of the orbit.
Edith, do you want to say anything about that particular condition which you've also buried in the literature?
Well, we have about a dozen babies now with this particular anomaly, and we've been extremely interested in the correlation of a failure of separation of the hemispheres and absence of the corpus callosum with the findings either of a real cyclops or what we call a miscyclops, the hypotelorism. Another interesting thing is that this particular anomaly is very apt to be associated with extra digits. I've seldom seen it in such conditions as anencephaly or hydrocephalus, but with this particular anomaly of the brain, you very often get extra digits.
We could go on indefinitely listing the variety of eye findings which suggest major abnormalities elsewhere, for example, colobomas, hypertelorism, microphthalmia, but all we can do with limited time is to stress the importance of using such clues in a search for major defects elsewhere. some mention should be made of the importance of examining for clefts or sinuses, especially in the midline in the newborn infant. This is particularly true over the occipital region, where the small amount of hair in the newborn permits a careful search for a small dimple, often with darkened hair protruding from the dimple. This may signify an attachment from the skin to the central nervous system, and if this is diagnosed early, unusual types of meningitis may be prevented. We will move on very briefly to abnormalities of the digits, which so often signify major abnormalities. Dr. Workney, would you say anything about polydactylism and its finding in major abnormalities?
Before I say that polydactylism may help in diagnosing certain syndromes, I should like to stress that it can occur in perfectly normal persons. And it is important for all these microsyndromes which have been mentioned here to keep constantly in mind that they can occur in normal people and that they have to be used with care and judgment, and we should not teach residents to make too much of such syndromes. So polydactyly can occur as a dominant hereditary trait in otherwise perfectly normal people. It is more frequent in Negroes than in Caucasians. However, polydactylism under certain conditions can be an indicator of such a syndrome as Lawrence Moon beetle disease picture. There we can sometimes diagnose a condition at birth by counting fingers. For instance, if there has been one child with the Lawrence Moon beetle syndrome in one family, there's a risk of 1 in 4 that this condition repeats itself. So if the following child has 6 fingers, it's very likely that we are dealing with another case of Lawrence Moon beetle syndrome in this family.
Would you say that this might also be true of the Ellis-Van Creveld syndrome?
That's correct. If we see in a child with chondrodystrophy or achondroplasia 6 fingers, it suggests that we are dealing with an Ellis-Van Creveld syndrome. And this may be of practical importance because irregular achondroplasia is a dominant, while the Ellis-Van Creveld syndrome is a recessive Mendelian trait. In giving risk figures for repetition in the family, this makes quite a difference. And there's another example that counting of fingers may be of value.
Dr. Potter, would you say anything about the abnormalities which might be found in the extremities of the newborn infant which could suggest Fanconi's anemia?
There have been a good many cases described in which there have been marked abnormalities or absence of some of the long bones, particularly those of the forearm. So that if you do have a child with a curving of the radius or an absence or a shortening, one must suspect that possibly you may have a profound anemia associated with it, and these children may need to be transfused over a period of a good many years. Eventually, apparently, most of them outgrow it.
One of the new terms I've learned from the pathologist here has been camptodactyly. Dr. Workney, would you tell us what camptodactyly is?
These are clenched fingers, and I, for one, had not paid too much attention to them until recently. And now we have learned that this is a very important part of the trisomy 18 syndrome. And at this point, I should like to make another remark. It is very strange that the trisomy 18 syndrome, which is now so well established, has been missed by clinicians for so many years until the chromosomal analysis came up.
The other digit findings or extremity findings that should briefly be mentioned are syndactyly, which have been reported so frequently accompanying acrocephaly, and sebocephaly. We should also very briefly mention clinodactyly, a curvature of the little finger of the hand, which is looked for so frequently in the child with Down's disease, but may be a perfectly normal finding or suggest other types of abnormalities. Edema of the extremities has been stressed again and again as an indication of Turner's syndrome. This edema is most marked over the dorsum of the hands and the feet. Club foot should indicate to the physician the possibility that other joints are involved and that the club foot may be part of a total picture of arthrogryposis, especially if there is no anomaly found in the vertebral column, which may accompany club foot. It is important to stress to the physician that examination and finding of what appear to be minor abnormalities of the genitalia, such as epi and hypospadias, may indicate the presence of major abnormalities of the genitourinary tract, and that careful intravenous pyelogram is indicated when these minor anomalies are found. We will not go into the problem of the intersex area in the newborn infant. It is important to stress, however, that the female with the inguinal hernia bears complete investigation as far as chromosomal studies are concerned. Finally, we could mention very briefly some of the skin findings in the newborn that have been stressed in recent years, namely congenital ichthyosis, which may be accompanied by cerebral palsy, incontinentia pigmenti, which gives rise to bullous lesions in the newborn and may be part of a generalized picture. Some stress has been put on the cafe au lait spots, which may in the newborn period be present and suggest an underlying Fuller-Albright syndrome, von Recklinghausen's neurofibromatosis, or even the newest of the neurocutaneous syndromes, ataxia telangiectasia. Now we move on to the significance of twin births. Dr. Bernerschke, would you tell us about the incidence of congenital anomalies in multiple births as compared with single births?
In multiple birth, anomalies are more frequent, but they're not the only cause for the higher incidence of perinatal mortality. We recognize two sorts of twins, as is well known, the single ovum-derived twins, which are also likened to be identical twins, and the fraternal twins, who may or may not be of the same sex. In general, it has been assumed that identical twins are identical in most characteristics. In series such as the ones we have collected, and there are numerous reports now appearing in the literature, one of identical twins is more frequently affected by a congenital abnormality than one of fraternal twins, a fact which has become known only recently and which we do not understand very well. It is important to recognize that among twins, malformations occur about twice as frequently as in singletons. And if one analyzes these twins for identical versus fraternal twins, the increased frequency is primarily due to an increased abnormality rate in one of identical twins rather than in one of fraternal twins.
Would you say anything about the significance of a marked discrepancy in the weights of twins? Dr. Potter?
We've been extremely interested in this problem of difference in birth weights, and in a study we're doing now on some 1,000 twin pregnancies, we've found that if one twin weighs in excess of 2,500 grams, the average difference in weight is 500 grams. I think the greatest difference in weight we've ever found was a pair where one weighed 2,500 grams and the other weighed 1,200. Both of these twins died, neither of them with malformations. And we were interested in the idea that we might possibly use the development of the kidney as an index of maturity. And in single pregnancies, we have never seen an absence of the nephrogenous zone in the kidney under about 2,000 grams. Rarely you may find it already stopped around 1,800 or 1,900 grams, but the average time when the kidney appears to be mature as far as new nephron development is concerned is around 2,300 grams. But in this pair, And this is an excellent indication of the fact that this 1,200-gram baby took as long to get to that weight as the 2,500-gram one did, because in both of them, the nephrogenous zone in the kidney was absent, so that we had here definite proof that these were both fairly mature babies. One other word about the relative frequency of malformations in so-called identical and fraternal twins. When we have a single chorion, our frequency of malformations in individual twins based on 1,100 twins or half that many twin pregnancies, monochorial had a frequency of 3.8%, while the others were 2%. So that this is twice the frequency in identical twins as in fraternal.
Dr. Benersky?
In my experience, the transfusion syndrome most seriously affects babies that are aborted before 28 weeks of gestation, and very frequently is the cause of severe hydramnios during twin pregnancy. And it's just those pregnancies that terminate prior to 28 weeks because of the severe hydramnios, because of the transfusion syndrome, and of course, in some states, such babies would be regarded as abortuses. We have included these in our series.
Dr. Warkany?
I would like to ask, how do you know about transfusion twins? How do you prove this?
I believe you can prove this quite readily by a careful examination of the placenta. If you're expecting the syndrome to be present, if one isolates an area in which one suspects such transfusion to have taken place, and then injects a rather large amount of fluid, say 50 cubic centimeters of colored water, into an artery of the small baby, the fluid will come out of the vein of the large baby, that transfused baby. And this has been shown over and over again and can be very impressive.
Shall we move on now to the second clue that occurs in pregnancy, namely polyhydramnios, or excessive amounts of fluid?
In my experience, the obstetrician facing hydramnios asks the question, why is the hydramnios there? And searches for a reasonable answer. The answers he primarily expects to obtain from careful investigation is there is an anencephalus or another severe anomaly visible by X-ray, and an X-ray is usually taken, or they're twins. If they're twins, he's satisfied. He says hydramnios occurs frequently in twins, and consequently this is the reason for hydramnios, and I no longer need to worry. I believe he needs to worry because the severe hydramnios that is discomforting to a woman during pregnancy with twins is the type of hydramnios which most commonly, in my experience, leads to fetal abortion because of this transfusion syndrome. And I feel that the reason for hydramnios, reasoning back from German obstetricians in the 1880s to our observations of the organ size differences in these babies, is as follows. The large twin being transfused and becoming larger because he is constantly transfused from his single ovum partner whom he is hooked up with through the placenta. This large twin has a larger blood volume, constantly increasing. He has a larger heart. He develops larger kidneys, and I believe he urinates more. After he's born, one can see that he urinates more, and the smaller twin urinates less. He is in a sac that is dry. The larger twin is in a sac that is very much filled with gallons of amniotic fluid. So I think the mechanism is to be sought there.
Edith, do you want to add something to this?
It would seem as if this meant that Kurt really thought that one of the main sources of amniotic fluid was the urination of the baby.
Would Kurt like to put on record his misconceptions regarding the formation of amniotic fluid?
Yes, you can read it in the literature. I have published my misconceptions some years ago. I feel that the fetus urinates. I think there's very good evidence that he does. And I feel that this urine in man has to go into the amniotic cavity. In animals, such as we have studied, in ruminants, this urine goes into the allantoic sac. And there, obviously, the amniotic fluid is derived from some other source. But in man, I believe, the major increment to the amniotic fluid comes from the urine. The turnover, in Plentel's terms, I believe, is achieved by many surfaces other than the deglutition or the inhalation. It's accomplished through the cord, fetal surface of the placenta and the skin probably of the baby. But the new formation, I believe, is from urine.
I won't let you call that a misconception, because I agree with you 100%.
Completely?
Completely.
Oh, I didn't think you would take that attitude. I thought there would be some difference of opinion here and that you wouldn't go along completely with
Well,
Kurt.
maybe I should make a little difference. I think that the source of amniotic fluid, certainly in the latter two-thirds of pregnancy, has to be primarily the urine from the baby. It is true that we have some amniotic fluid very early, almost as soon as the morula becomes further developed in the very early stages of development. I am not prepared to say that I would agree 100% with this statement you just made. But certainly, nature's experiments in the various kinds of malformations that we see give you, to my mind, very convincing evidence that the kidney function is primarily the source of amniotic fluid.